الحمد لله رب
ايه
العالمين.
الاخبار؟
الحمد لله تمام، الحمد لله. الحمد لله.
ابتدي ولا استنى شويه؟
لو نستنى 3 دقايق كمان كده بس ندي فرصة للزملاء يدخلوا يبقى كتر خير حضرتك. ايه
لا مفيش مشكله، مفيش
ربنا
مشكله.
يحفظك. ربنا
خلاص، الله يخليك.
فيكم حد داخل امتحان بكرة يا شباب ولا كلكم لسه مش في المرحلة دي؟ حد موجود داخل امتحان بكرة؟ طيب على كل حال بالتوفيق للي داخلين إن شاء الله. ما وصلناش، هتوصل يا دكتورة إن شاء الله، إن شاء الله. دكتور محمد مش موجود عشان نسجل المحاضرة.
الدكتور محمد كان موجود.
ماشي، العفو العفو يا دكتور محمد. أنا بس كنت يعني لو حضرتك مش متاح كنت هسجلها، فحضرتك ما تسكتش على نفسك يعني. المرة اللي مش متاح بالنسبة لك قول لي وأنا أسجلها. ماشي ماشي، كتر خيرك والله، قايم بدورك كبير يا دكتور محمد، ربنا يحفظك يا رب. يحفظك، ربنا يحفظك. حضرتك تقدري تبدأي يا دكتور ليلى عشان برضو وقت حضرتك، وهم الزملاء هيدخلوا تبعني إن شاء الله.
خلاص إن شاء الله. مساء الخير يا جماعة. أنا دكتورة ليلى رواش. أنا في مستشفيات جامعة عين شمس، وأنا دلوقتي حاليا أنا مديرة وحدة إشعة الأطفال، و I have special interest in contrast studies. الأولد ستايل contrast اللي هو bariums والascendings وكده، the old school. خلاص، وشرف كبير أكون معاكم النهاردة. أوكي، فأنا I will discuss the common GIT disorders in children. Okay. عايز يقلب ليه؟ Okay. We'll start from the upper GI and continue distally. First thing is first, esophagus. One of the common studies, common abnormalities that is seen in the esophagus is atresia with or without tracheoesophageal fistula. The most common one is the upper end, blind upper end, and the lower end connected with a fistula. Okay, that's the most common one. Usually we do not see these. They are dealt with by pediatric surgery, and they don't come initially for workup in the radiology department. Even though it's the most common, we don't see it that much. What we see day to day mostly is isolated tracheoesophageal fistula. Patient comes with choking during feeding, and this turning cyanosis, kida, they come and we do a barium swallow for these. This is the one we see the most. Okay. What should we, what should be in our minds when a patient comes with the possible diagnosis of tracheoesophageal fistula or atresia with or without fistula? Ask the mother, was there polyhydramnios? Okay, usually the patient's small, okay, especially if it's a blunt, the proximal esophagus is not connected. It will be diagnosed almost immediately after birth with the first few feedings, okay? As well, we must check for other abnormalities, the workup. Vertebral, musculoskeletal, GIT, cardiac, urinary, are part of vectoral diseases. As well, When they come, they come in, what should we look for initially in the plain X-ray? In the plain X-ray here we see, we should look for two main things. What I see is, here's a radio-opaque tube in the oropharynx and going down to the upper esophagus. It's not the airway because the airway is seen here beside it. As well as the gut shows very good aeration. So this is also a clue. If it's well aerated, so the air must be getting into the gut by some means or other. Here it is on lateral. The ryle tube is posterior, the airway is anterior, but it stops up here in the upper thoracic esophagus. We did a contrast study, and we found a blunt upper end. But as well, so this tells us, with this confirms it's blunt upper end, but the distal end is connected by a fistula to the airway. Okay? Usually what happens with these patients is they get this blunt upper end, they do it for an esophagostomy and to open at the root of the neck, and a feeding gastrostomy. This is what the fistula looks when we do direct association, okay? Direct visualization, which what we do is best is when you do it with a ryle tube, so you can control the flow of contrast. And we should try as much as possible to use low osmolar non-ionic contrast. We'll try as much as we can and avoid barium, and especially avoid high osmolar contrast. This is completely contraindicated and may cause pulmonary edema. Okay, here's another case. The majority of the cases in this presentation, the contrast are from our unit, okay? This is here, it has feeding gastrostomy, a radio-opaque tube is seen here at the area of stomach, okay? The patient used to come with choking during feeding, and it has a history of tracheoesophageal fistula with the blind end coming out at the root of the neck. So we thought, well, what is going on? Why are they asking for it? So when we did inject it in the stomach, there is a bit of gastroesophageal reflux. And the more reflux happens, then all of a sudden the airway, here you go, this is the carina and the two main bronchi are here visualized, and this is the connection. So this patient would have to go in to surgery to ligate this fistula. Here it is in lateral. Okay, foreign bodies and perforation. This is as well something sadly very common and deadly. These are usually under 3 years old, usually moving around. They have to usually crawling. A patient is crawling or walking. They find something on the floor, something hidden in somewhere. They will inhale it or swallow it. Usually they swallow it. Okay. The most dangerous are button batteries. البطاريات اللي زي البطاريات اللي في اللعب دول أخطر حاجة. Within 2 hours, they can perforate the esophagus and cause a traumatic tracheoesophageal fistula. These are very, very dangerous. When they do a plain X-ray, where does it usually stop? It stops at the thoracic inlet. That's a site of anatomical relative narrowing. The button battery is quite large, so it stops here. Always do a lateral, just to make sure it's not in the clothing, it's not a button, زرار في الهدوم, أي حاجة زي كده. You will see it posteriorly, the airways anteriorly. This is all you have to do is confirm. And they go straight away for a endoscopy retrieval. Here, you can see right here at the same site, fistula. Okay, post-corrosive. Sadly, it is still present. It's very common. It's been caused by potash, chlor, مية نار، في حاجات جديدة اسمها power now، في flash، حاجات دي they are very caustic. بيحرقوا الأسوفجس and they can cause fistula, the most severe. If not a fistula, they will cause trauma to the esophagus and will cause strictures. What I found is the more severe or more caustic the substance, كل ما يكون المادة حامي or strong, it affects the the cervical esophagus. Okay, why do we not in as barium we don't do it in contrast? We don't do it in early stages because they could have perforation and things. You can do it in CT, okay? But in early stages, if the patient is not improving, you must rule out, or if it comes respiratory distress and this, you must rule out perforation, esophageal perforation or fistula, okay? Acids are sour and they spit it out early and they cause shorter stricture. Alkali are relatively milder taste, but produce liquefactive necrosis and cause longer irregular strictures because they drink more of it. Okay? And what ده المشكلة. Okay? We've all seen it, and the patients come and they do multiple dilatations. They do dilatation once a month, once every 6 weeks, and usually they have a feeding gastrostomy. Okay, here we go. This is the most common site, just distal to the bifurcation. Here's the bifurcation of the trachea. It's at the site of bifurcation. Why? Because the left main bronchus goes across the esophagus, and there's relative stasis. It's relative, okay? Stasis at this site, so that's why usually the stricture starts here and goes distally. Okay, that's for potash, okay? ساعات the potash, it comes in crystals. الأطفال بيشوفوا الكريستالز بتاع potash بياكلوها بيرقشوها. So this will cause, not down here, it'll cause up cervical. Here, like here, mid-cervical. And these are very difficult to deal with surgically. Surgically, they do colon bypass. Here's another one. And even in this one, there's a bit of esophageal shortening, and it has a tiny hiatus hernia here. This is the sequelae of it. Okay, here, multiple areas with proximal dilatation, irregular wall. Okay, atherogenic rupture. Usually it's from a nasogastric tube. It's put in roughly, and the child is fighting or resisting. That's what happens. Usually these are self-limiting, and they go for time, no oral intake, and they heal. But they may cause strictures. And here on CT, you can see this area. GERD. Now, there's two GERD, means gastroesophageal reflux and gastroesophageal reflux disease. What's the difference between the both? Everybody has a degree of gastroesophageal reflux, but if it becomes so severe, a D is put, disease. It causes symptoms. Okay, what is more common in younger children? Gastroesophageal disease. They come with vomiting, they come with aspiration. What's more common in older children? GERD, okay? There are certain diseases that have GERD as a common association. They have severe vomiting all the time, neurological disease, CP, other neurological mitochondria, post-anoxic, all these neurological problems have usually severe GERD, gastroesophageal reflux disease with repeated vomiting, repeated aspiration, pneumonia, this kind of things, okay? If you, some people say you do you can do maneuvers to show the reflux more. No, this is false. You overestimate it. If it and as contrast, we are not the first line for diagnosis or the GERD. GERD, it's gastroesophageal reflux. Everybody has a bit of reflux. HCl gastric juices go from the stomach up to the esophagus. But everybody has a minimal amount. But when the reflux is so much of the gastric contents into the esophagus that it's causing symptoms. The disease is from symptoms, okay? That's the difference between the two, okay? We don't do siphon tests. All these are found to be not accurate and are not used. But what is very good for detection of GERD is isotope, where they inject technetium into food. And they do it, but because this is takes a long time, it needs special machines, special thing. That's why you can do a barium swallow. But just that we don't see it does not mean they don't have it, okay? Because you don't have reflux all the time. Usually it's after a feeding, okay? Here we go. And as well, in here, it can be minimal, a bit like this, and always look esophageal junction, because as well, why do they do studies? To see if there's associated hiatus hernia or any abnormality. Maybe they have gastric outlet obstruction, and this is causing reflux. But that's the main, that's why what we do the barium studies for. It's not necessarily to diagnosis, but to diagnose anything associated with it. Because now the American Society of Pediatrics said if you give them oral treatment, if the symptoms improve, that's enough to diagnose it, because it's very common, okay? Here, there's a little bit, see here, it was a little bit of contrast. Now it increases. Sometimes it's very severe, goes up to the cervical, and they may vomit. Okay, here it is again. And the gastroesophageal junction is down. Here it moved up a bit, so there's a little bit of hiatus hernia. Stomach. Okay, we'll finish this up because now we're into the stomach. Duplication cyst, okay? A duplication cyst can be found anywhere in the GIT, and where it's found, it's called the duplication cyst of the stomach, of the small intestine, the large intestine, this, okay? In the stomach, it's attached to the greater curvature. It doesn't usually communicate to the GIT. It's just found as a swelling, okay? And here's the double wall sign or the gut signature sign. Here it is. Ultrasound is the best way to diagnose these. Here you go. Here's the liver. Here's the stomach, and here it is. Target sign. This is all the layers of the muscle, the mucosa. This is all of it along the greater curvature, okay? That's called the gut signature sign. Here it is. Here's one associated along the greater curvature, and it pushes the transverse colon. And here it is on CT, on ultrasound. And here it is. You can just see it outlined here. Okay. Pyloric web, diaphragm, or atresia. These are all degrees of obstruction of the stomach. Okay. Gastric outlet obstruction. Okay. What's the most common symptoms? Vomiting. Bilious or non-bilious? It's non-bilious vomiting. Usually in pediatric group, non-bilious vomiting is not a surgical it's not surgical case, it's more routine pediatric. you get more nervous with bilious vomiting. This is usually more severe. But pyloric atresia, of course, this will be diagnosed very soon after birth. Any atresias are diagnosed very soon after birth, within the first day or two, okay? Webs and diaphragm may take a longer time. They may be older children. I have seen maybe 12, 14 years old, and they were never diagnosed, okay? And any prenatal indications, any atresia is associated with polydraminus. Okay, here, you will see just air in the stomach, nothing distally. Fill it up with contrast, no air, and obstruction. This will, and it will vomit, they'll vomit the contrast. Here you go, filling defect here. And here's a very nice image of a web. There you go. Well, this is a big child, and distally there's very little air. This is, you can see here in the contrast, there's filling defects. This is food. And this is what you call a caterpillar stomach, where it's several, the peristalsis makes several balls like a caterpillar. And you follow up, but this can as well happen. This is like gastric outlet obstruction. And sometimes they will get, they have chronic obstruction and they have acute on top of chronic. So we have to be mindful. Volvulus, this is very important to diagnose, and it's quite an emergency. There's two types of volvulus. How I remember them is, if it's along its long axis, it's organoaxial volvulus, and it goes like a zero, an O, okay, like a zero or a O, okay. Mesenteric, along its mesenteric axis, with the pylorus and gastroesophageal junctions coming close to each other, like this, it may look like an M. It looks like an N شوية بس يعني إيه, it doesn't look like an O. This looks more like an O. These are more in newborns. This is in older children and adults, usually, okay? Here, the stomach is quite big as well, because when there's volvulus, there's rotation, it causes acute obstruction. And volvulus may come and go, so they come in attacks of obstruction, and then it becomes relieved. Severe vomiting, dehydration, and then it undoes. So these can be misdiagnosed or be quite old by the time they're found out. Okay, here you see on CT, here's the area. An M, mesenterico-axial volvulus. Okay. Okay, here it is again. The greater curvature and lesser curvature are rotated, okay? Here you go again. You can clearly see it here. Okay? And another one here. But there's without obstruction as well. In a report, you must mention whether there's an element of obstruction, yes or no. Hyperchips. This is commonly seen, but it's not commonly coming to contrast. It comes to ultrasound. And ultrasound is enough for diagnosis, and it's enough for the pediatric surgeons to do surgery. This is enough. There's no need to expose these children to radiation and contrast, okay? Ultrasound is the modality of choice in diagnosis. Muscle thickness, it's 3 millimeter, one side, single layer, okay? Pyloric transverse diameter of more than 13 millimeters and the length of more than 15, okay? But you have to make sure it's stenosis and not spasm. How do you tell the difference? Usually spasm is not as thick, okay? And as well, you wait and you look longer and the spasm will be relieved, okay? When you're doing it's non-bilious vomiting, and it starts at between maybe 3 weeks, 6 weeks, maybe up to 12 weeks. And they were fine, and all of a sudden they started vomiting, okay? Is this normal or abnormal? Usually what you do is you get it's difficult to find it, okay? But when I used to do ultrasounds, how would we see it? You look for the liver, here's the gallbladder, it's right here. If you don't see it, like here, you don't see it in enlarged pylorus, then usually it's not enlarged, okay? Here you go, cervix sign. And it does look like the cervix of the uterine cervix. Here you go. Thick, here's the wall, 2 walls, and here's the mucosa in between. Here you go. Here you measure the length from the beginning of the length, and here's the gallbladder. You can see it here, and you measure it. If you can't see it still, have the mother feed the child. The stomach contents will come to the end, and it'll do like a window. So you follow there, okay? Here is an older one that wasn't diagnosed, and the stomach becomes huge if it's left. Here's the contrast ones. Beaking, like a little beak here. Here's tract sign. You can see the pyloric canal enlarged, elongated. Okay. Shouldering. This is all from this is the muscles here at this area, and this is what causes it. All this is muscle here. Sometimes these come. 5-year-old, nervous, a child, sometimes girls, sometimes boys. Usually there's something going on in the family. Nervous, something like that. They pull their hair. Usually it's hair, but it could be anything. And you will find bald spots in the hair where they pull it out and they absorb it. You'll find the stomach is quite enlarged. And look here, filling defects. And you ask the mother, are you fasting? Because they should be fasting. You'll find filling defects. Okay. There you go. But it's not obstructed. Okay. But they get filled quickly. Okay, move on to the small bowel. Okay. Duodenum, atresia, stenosis, and webs. Okay. Once you get into the duodenum, it turns into bilious vomiting. Okay. As well, there's associated duodenal abnormalities are more in Down syndrome. So once you see a child with Down syndrome, even if they're coming for a swallow, for a suspected GERD, always continue to make sure the duodenum is normal, okay? With the atresia, this is a newborn here, you'll find double bubble syndrome because the air went into the stomach and here, but there's nothing, no distal aeration. There you go. Here's even the umbilical cords here with the clip, double bubble syndrome. Okay. If it's stenosis, here's the stomach. Here's our double bubble. This is an older child here. You can see by the epiphysis here. There's aeration distally, but not that much. Okay. Here we go. And you follow up, you can see. This is also an older child. There you go. significant dilatation, significant. And here's the site with the food, reflux. A lot of times, you see how huge it is, نعم؟
بعد إذن حضرتك يا دكتور ممكن الصورة اللي قبل دي؟
دي؟ البلين؟ ولا اللي قبل ده؟
لا هي دي.
أيوة.
اللي بعدها معلش يا دكتور.
أيوة.
هي ليه الاستومك يعني ليه الاستومك على اليمين، هو قلبه كمان على اليمين قبلها.
مش
أيوة هي دي.
هو
ده سايتس؟
لا مش سايتس، هو ده this is مش عارف. ساعات sometimes with the old machines some of these are sometimes they reverse. بس it can occur in situs. بس here it's the site. بس انت معاكي حق. بس ده فيلم برون.
فيلم برون. تمام.
ده برون.
ماشي شكرا.
Okay.
شكرا تمام.
Okay, because with meal we have to do supine and prone. And even if this came for swallow and you found the stomach huge like this with feeling defects, you have to continue. Just that the clinician asked for a swallow, but if we find something else wrong, we must continue. There's no need for the patient to come again, because as well, something like this, the contrast will hang around in his stomach for a while because they have chronic obstruction. Okay? Here we go. A very nice thin web. Here's another one. Okay, malrotation with or without volvulus. Okay, this is as well comes to us regularly. It's part of a differential diagnosis of vomiting. Okay, it's usually bilious vomiting, but it may start non-bilious, of course, in the beginning, and then it comes bilious, and it'll come as well. It can be in the newborn period or older. And it usually comes as attacks. In fact, the patient may not be diagnosed until they're older because they say, oh, they ate something bad, they have this and this, okay? But when any routine gastric meal studies or follow-through studies, you have to show the duodenal-jejunal junction, okay? Duodenal-jejunal junction. Where is this? It's not a point. It's an area. Okay. The duodenum should curve and then go over to the left side. Okay. Wait a second. Should go over to the left side, and the small intestine should be here. Okay. The jejunum should be here. But in this case, this is not it. Here's the stomach. It's a little bit big. Okay, and where is the small intestine? Seen over to the right side. Not only that, there's the characteristic appearance of the corkscrew. We don't use corkscrews, but it's spiral. You see here, goes like this, and then it goes over to the right side. Okay, so that's malrotation with volvulus. Malrotation is the duodenal-jejunal junction on the right side and inferior not on the level of the pylorus. This duodenal-jejunal junction should be midline or to the left at the level of the pylorus. If it's anything else on the right side or below the level, there's increased incidence of volvulus. Volvulus means what? It rotates around the mesentery, okay? As well. When we do these, if there's malrotation, sometimes they ask for an enema. Why? Because if there's malrotation, abnormal site of duodenal-jejunal junction, the cecum, which is on the same mesentery, that's the two areas in the intestine that have fixed positions are who? The cecum and the duodenal junction. Okay. Other than that, the gut can be mobile. But these are very important. So for sometimes they may ask to do an enema. Why? When the meal is done and it's not done properly and we can't see where the duodenal junction is. But this is very important to do your images early on to make sure before the jejunum fills up and we can't see where it is. Okay. Bardo, a band of lad is a part of this fixation, can obstruct the duodenum. Okay. Before it goes to the liver, direction of the liver. As well, sometimes they will ask for a ultrasound. So how do we know by ultrasound? Let's say there's no contrast. How do we know by ultrasound? We have to know the orientation of the superior mesenteric artery and vein. Okay? Okay, here's the stomach and duodenum. Once you find the artery should be left and the vein should be right. Okay? If they're opposite, and like in this picture, whirly, the spiral, the same as spiral as that is an indication of malrotation, volvulus. Okay, and here it is on CT, and here's a bit of air as well in the gut. So this tells me this is gut because there's air. Okay. Meconium ileus, okay. What is it as meconium ileus? This is delayed passage of meconium, a newborn with delayed passage of meconium. What is it associated? If a child is diagnosed with meconium ileus, you have to make sure that it's not associated with cystic fibrosis. But when they get a bit older and stuff, they have to do the workup for cystic fibrosis. As well, meconium ileus it has a higher association with Hirschsprung disease, disorders of the colon, the function, the function, the peristalsis, anything meconium ileus, you have to rule these out. Okay. What can happen in utero? It can cause perforation of the colon in utero. It's not that common, but it has happened. And okay. Calcifications. How do we see it? By calcification? Meconium ileus. If a child is diagnosed for meconium ileus, for dear colleague, meconium ileus for your kind care, what contrast do you use? Do you use barium? Contraindicated. What do you use? This is only in children. This is the only reason to use high or smaller contrast in pediatric age group is meconium ileus. Why? Because it causes fluid shift from into the colon, will cause like diarrhea. It'll increase the fluid into the colon, so it'll cause meconium. It'll make the fluid around the thick meconium, so helps it. Okay. You can see here's a newborn with all the leads, no epiphysis. Okay. You see here, what is this here? You can see here, a bit of calcification with like a rounded, homogeneous with thin lines of calcification pushing the gut on to the opposite side. Okay. Meconium peritonitis with cystic form as well. If you do an ultrasound in the NICU, okay, or PICU, and you find with calcification, that's what your diagnosis is. Okay, here you can see it close up. But really, we don't see that often. Okay, here it is on ultrasound. There's layers. Okay. Okay, here it is again. What do I see? You see multiple dilated, in newborns, it's upper and lower intestinal obstruction. Okay, so this will be considered a distal intestinal obstruction. And I don't see here in the Distal bowel, there's no aeration. This gives me you say, well, maybe not the stomach, but he has a ryelin. So that may, when you inject it on contrast, you can see it. You can see microcolon, but what do you see in it? Filling defects. You can see that. This is all the meconium. Here you go. It's like and if whoever is doing the study, the residents, which are when you do these studies, you must write the reports and help whoever's writing the report, because what you see on table is very important, because you will say, when I was doing the study, what is all this? It's the meconium. And we'll see it later. You can see what it looks like. Green rope. It looks like a long green rope, and for that duplication cyst, I mentioned it before. Duplication cyst. It's usually as a cyst, and it pushes the gut. It's a space-occupying lesion, okay? It doesn't communicate with the GIT, okay? But it may cause intussusception, recurrent intussusceptions. Very important if someone's coming for an intussusception, not at this specific time of year with viral and this kind of thing. Look for something that causes intussusception, whether it's a duplication cyst, Mickel's, diverticulum, polyp, something like that. Recurrent intussusception, look for, it's not your usual lymph nodes and viral infection. Look for something else, okay? Here you go. You can see it here in the contrast, and here it is. Okay, Mickel's diverticulum, okay? Mickel's diverticulum, usually it's asymptomatic, but it may cause trouble. What is it? Most common cause of painless rectal bleeding in infants and toddlers, or what they call red currant jelly stool, that kind of stuff. It may lead for a point of intussusception. This is very important because they come for ultrasound. You have to rule this out, okay? It can have 2 types of tissues inside, okay? It's a diverticulum. The rule of 2, in 2% at 2 feet, and it may have 2 types of, it may have gastric tissue. It may have more than 2, but most commonly the gastric tissue or the normal ileal tissue, small intestine, okay? It may be mistaken for appendicitis as well. It could be intussusception or appendicitis, but for its location, which is around the umbilicus. It's usually found around the umbilicus. Once you find something around the umbilicus, either look for the cecum malrotated, not in its normal pace, or else Mickel's, okay? And what's the best known isotope? Here it is, rounded, filling the, here you go. This is complicated, it's gone to the anterior abdominal wall. Here you go at the level of the umbilicus. Okay, another one. Midline with the fat, you can see the abnormal fat surrounding it, inflammation. There you go. And it's painless lower intestinal bleeding. And the patient may go into anemia, okay? Why? Because the gastric mucosa secretes HCl, okay? Which the HCl and the gastric juices, the small intestine is not used to gastric juices distally, so it will cause like ulcers, and that's what causes the bleeding, okay? So you can see it here, abnormally here, okay? Intussusception, usually ileocolic or ileocolic, okay? With these, they're looking ultrasound, okay? And ultrasound may not only be diagnostic, ultrasound may be a part of the therapy when you inject water or air, and using the ultrasound injected through the rectum, and you follow with the ultrasound probe to see it undo. Okay, necrotizing enterocolitis. Necrotizing enterocolitis is a severe disease. It's in the nucleus, in Mahda. Okay, the more premature, the more severe the disease, especially if it's breastfed. It has something to do with the gut and the microbiome, and the feeding, and its inflammation, which causes destruction of the wall of the gut. Okay, the characteristic finding, we'll see it. Okay, and what will happen? When you look at this plain X-ray, you see it's a very small child, and you can see the abdomen is kind of distended. You see here, it can occur anywhere, but usually in the distal bowel. Okay, it can occur in the stomach. Like here, the stomach, it looks nice wall, nice thin outline like here. But when you see here, you see, what's this? Why does it? The junior doctors say, well, you can see lines, black. Black in a plain X-ray is usually air in the walls. Okay, air enters in the walls, and it enters into the portal system. And later on, here you go. And this is the liver. Okay, you can see the air within the portal system, and you can see here. Here it looks fine, it's okay, but here, distally, it looks, it's very characteristic, the images. Okay, so you can see it as well here. Here's quite severe. And here it looks like there's rupture bowel. You have to make sure it hasn't ruptured. If there's rupture bowel, they have to do a colostomy. Okay, so here's air on the lateral wall. Okay. Okay, anorectal malformations. This is quite common. Coming to our place, we have maybe several cases a week. Okay, when you do anorectal malformations, it can be either male or female. And according to the severity of the malformation, okay, you look for different things. Whether you have to rule out for any anorectal malformation, they have to do a complete workup to look for anything associated with it. Neurological association, bony spine, they have to do an MRI. They have to do workup of MRI for not only the lumbar spine and sacral, distal lumbar and sacral, they have to do workup for as well the sphincters. Why? Because when they correct it, if the sphincters are not there, the patient will never have bowel control of the bowel movement. They will be always incontinent. So that's why not only do they come to the contrast, they also do MRIs, okay? As well, they may have vertebral, cardiac, tracheal, radial, and limb abnormalities. Look for these, okay? Males, they have a fistula between the urinary tract and the distal blind end of rectum, okay? As well, bones, always check when we're doing it, look for vertebral and abnormalities. That's without the limbs. That's the workup. But when they come in, they do an immediate colostomy. If they have imperforated anus, they have to see high or low. High type, they do a colostomy. Then they come for a distal lupogram with us. We have to rule out fistula. Okay, this is very, very important. Okay, it depends on if it's a male or female. Okay. this is very common in males. You have to rule out a rectal urethral fistula, especially a bulbar, okay? That's the most common, but it may be prostatic, okay? It may be higher up, okay, bladder neck, okay? May not. It may not have a fistula, but you have to inject high pressure. I'll show you now what high pressure looks, because sometimes the fistula is very thin. It may be obstructed with mucus or meconium if they didn't wash out, because when they do the colostomy, the double barrel colostomy, the surgeon should wash out the distal barrel, the colostomy, okay? So it doesn't cause inflammation, okay? Females, a cloaca is associated a severe type of anorectal malformation, okay? Cloaca means all of the perineum opens into one single opening, okay? That's it. This needs general anesthesia for doing this. It's not just simple distal lupogram. Vestibular fistula, okay, or vestibular anus is less severe, where the anus is instead of being posteriorly, it's considered a mild type, okay? And cloaca, there's different, according to the channels, they have different classifications, okay? Here we go. As I said, this is a very young newborn, okay? You look, well, there's good aeration everywhere, okay? But you, as well, what I mentioned, what you have to look for, if something goes wrong, usually in the human body, when something goes wrong, you have to look for anything else going wrong. Like here, the rectum is wrong, the distal opening into the perineum. Check for the spine. As well, it's commonly associated with kidneys. So they usually have to do a pelvic abdominal to rule out any other abnormalities. Here you can see the vertebrae, here you go, abnormal. Okay, you can see it later on when you do the lateral. Here you go, fused. Okay, here you get the Foley's catheter, blow up the balloon, and you inject. Is this good enough? No, it's not good enough. You have to inject under higher pressure. It has to be ballooned out. And when you inject, you will feel pressure. That's why it's called high pressure. The Americans use in its name high pressure. Okay? If you don't do it under high pressure, and the patient has to be lateral. Okay? AP is of no value. Okay? So here you inject, you see the difference now between this one and this one? It becomes distended and the walls become ballooned. And what came here? Once you find a small little tract coming out here, here you go. What's anterior to it? The bladder. And then they do micturition. Okay? There's another one. The spine looks normal here. This is a girl, and this is complex abnormalities, you see? This here is the distal loop, very high up in front of S1, sacrum, and it goes between septated vagina. And because what's in just anterior in girls, in boys, it's usually a fistula with the urinary tract. In girls, fistula with the female genital tract. Okay? So not only is the vagina hugely dilated here, it's septated. And this is inserted here. In these cases, they may do a vaginostomy. Okay? To relieve the pressure in the vagina. Here's the usual boys. Here you go, here, and here's the bladder. You can just see it here. If you're injecting, once you see this, it goes in a little booth, عامل بوز رفيع كده, that's when you know there's usually a connection. And here's the AP image. Okay, sometimes it's quite difficult, like in this case, there's contrast everywhere. Okay, but you have to inject under high pressure. Hirschsprung disease. Hirschsprung disease, it's one of the, it's increased in the failure of passage of meconium during the first 24 hours. Okay, that's the history. Usually it's a boy, and an oldest firstborn boy in failure passage of meconium within the first 24 hours. That, when I hear that, I say, you think of Hirschsprung, okay? If it's severe, it can cause bilious vomiting in newborn. So you see how fragile newborn children are. At the rectosigmoid area, there's a spastic area that does not relax. It causes obstruction. It causes bilious vomiting. So you see, the most distal part of the gut can cause bilious vomiting, and the children can become dehydrated and decompensated in this. Okay? Older children can have diarrhea. How can they have diarrhea when they have chronic constipation? It's a cause of chronic constipation. Okay? With the stasis of fecal matter, it can cause diarrhea. Okay? As well, the problem with Hirschsprung disease, if it's not severe and doesn't cause bilious vomiting, what is the problem? It can cause enterocolitis. Enterocolitis can be deadly, but we have to pay attention to this, okay? But Hirschsprung disease is not a diagnosis. We don't do the diagnosis. You say in your impression, in your report, a picture highly suggestive of Hirschsprung disease, and they do a rectal for histopathology confirmation. They do a rectal biopsy, okay? Total colonic Hirschsprung, we don't diagnose total colonic Hirschsprung. What we say, it's a case of microcolon. Total colonic Hirschsprung is where they go and take multiple biopsies from several layers, several sites along the colon, and that is and then they say it's total colonic Hirschsprung. Here you go. You see, there's not that much gases. Here you go. It's at this as well. What we see is an important measurement for Hirschsprung disease is rectosigmoid ratio. The rectum should be the largest diameter of the large intestine. The largest diameter of the large intestine. The sigmoid, this is in small children. The sigmoid should not be larger, as you see here. You see how large it is here compared to here? If it's larger, that means it's acting as a reservoir. That means there's some sort of obstruction. Here it is. Usually it has irregular contractions, tertiary contraction, and this is the site of the Hirschsprung. What contrast do we use? Contrast we use is water-soluble contrast. Okay, why do we use water-soluble contrast? Because barium has a tendency can cause impaction. If it's impacted, it may cause, these children have chronic obstruction. If you use barium, you may cause acute on top of chronic obstruction. And they may do, I have seen children done colostomies. But it's very important to use the proper contrast. Let's say we don't have enough water-soluble contrast. What should we do? You have to do a rectal wash immediately after the study. Okay? Why? Because to avoid this, the impaction. It's rare, but it can happen. Okay? When you use water-soluble contrast, you take a film, 24 hours, 2 post-evacuation films. You take an early, immediate post-evacuation evacuation film and a delay, 24 hours or 48 hours. When it's 24 hours, usually we do 24 hours, not 48. If there's still retention with this, it is Hirschsprung disease. Here's another one. You see hugely dilated colon, and here we go. Irregular here, narrow. Here, look at this plane. Here we go again. And this is starting with the irregular wall, irregular outline you see here. And here, this child is getting into enterocolitis. This is a very nasty turn. Here we go, tertiary contractions again. Here you go. This is a long, usually it's not this long, but it may be long, it may be short. You mostly at the rectosigmoid junction, but it can be anywhere. And as I said, it could be a total colonic Hirschsprung disease. It couldn't be the whole colon. Here we go again. When as well, please, anybody doing these, here, there's even enterocolitis up here. When you do this, the patient, when you fill it up this much with contrast, you may overload the colon and you may cause acute intestinal obstruction. So you have to, as well, give the patient, if the mother can do rectal washes, which usually, if there's a preliminary diagnosis of Hirschsprung disease in newborns or in a few months old, they teach the mother how to do rectal washes until they can plan the surgery. This will cause the child, will cause bilious vomiting. So you inform the mother before you come for the film, the next day, the 24-hour delayed film, if the child is vomiting, bilious vomiting, and has a rigid abdomen, distended abdomen, do a rectal wash, or else come back to the hospital and the emergency room and they will do rectal washes because we have overfilled the colon. This is very, very important. I know the exam is important, but as well, the exam comes and goes, but working every day, this is very important. Okay, here we go again. There you go. This is an older child. And enterocolitis has started here. You see the rectum, how huge it is, how the sigmoid, how huge, and there's enterocolitis. Okay, this is the post-evacuation film. There's retention here. Here you go, another one. A long segment, okay? Another long segment with significant dilatation. It may be long, it may be short. And here, post-evacuation, the delayed post-evacuation. And this is not barium, this is water soluble, you can see it. With the tertiary contraction and as well with the fecal matters here. Okay, as well, post-evac, significant dilatation, and the rectum is spastic. You see distal colon, the rectum is narrowed and this is spastic. Once you find a narrow rectum, that's another clue. This is called transitional zone, where it transitions from narrowed to dilated. This is very important. With the modeling, you see here, it's called modeling. When you see that, that's an indirect sign of Hirschsprung disease.
Doctor,
Huh?
what are the imaging findings of enterocolitis?
Enterocolitis, what we see is, here you go, I'll show you enterocolitis. You see here, enterocolitis means inflammation. When I say enterocolitis, inflammation of the wall of the colon, okay, enterocolitis, enterocolitis. What do we see? We will see thickened mucosa, شايفين هنا? You see the mucosa here? You see it's not smooth like here. The outline is irregular, شايفين? خلاص? We're here, there's black spots, there's spots. It's not smooth like here and here. خلاص? That thickened mucosa, irregular outline, that means there's inflammation. خلاص? But this is very important as well. In these cases, enterocolitis may cause perforation. So when it's not a contraindication to doing the case, unless you have to do it carefully. okay? As with everything, you have to be careful. Like a distal lupogram as well. You inject, you're under high pressure, but not so high you perforate. This is as well, okay? You see here, irregular outline. And then, as well, it's commonly associated with modeling. You see this spots here in the contrast. برضو ده اللي هي ايه retained fecal matter, okay? You'll find it spots. خلاص, it liquefied. It becomes fecal matter عادة في المعدة, where the bacteria in the gut is working on it. Is commonly associated as well with diarrhea. Enterocolitis, you have diarrhea, abdominal pain. خلاص. On imaging, you'll find mucosa, irregular mucosa, خلاص, with irregular outline. Okay. شايفين هنا؟ هنا is nice and smooth outline. You can draw it with a pencil. هنا لا باينة. شايفين هنا؟ It's not smooth. Okay. ففي element والmucosa اهو. There's lines here. Can you see? That's the thickened mucosa. Enterocolitis, but they have to be careful because the patient should be admitted to the hospital and take intravenous antibiotics. So it's very important. This, no. Is this enterocolitis? Well, you can say it's irregular wall. No, but this is contractions. شايفين? From one end to the other. Tertiary contractions. There's a big difference. Hannah, there's no enterocolitis. It's a straight wall. شايفين? But there's no colitis here. وحتى there's a large fecaloma. Impacted, يعني ده fecaloma, ball of fecal matter with obstruction, chronic obstruction. شايفين هنا؟ ده عنده enterocolitis. شايفين؟ مش بس كده, thickened presacral space. There's some sort of infection has come around to the tissue around the rectosigmoid junction. Okay? فبرضه this is a bad sign. Okay, CT, a whole huge dilated, we're down here in the pelvis, colon, and here you go. Can you see the junction? Okay. Total colonic Hirschsprung disease, it's microcolon. It's but you mention it, but it's not our case to call. But if it's in a Down syndrome, you can say total colonic Hirschsprung disease must be ruled out and a cause of microcolon. Here you go. Thin microcolon, featureless. Okay. Meconium plug and small left colon syndrome. All of these are in newborn. Okay. They overlap with each other in Hirschsprung disease. اللي هي كلها microcolon. Okay. Meconium plug, a long plug of meconium is seen. Okay. In the colon. But the difference is from Hirschsprung disease is the rectum is normal in small left colon. In Hirschsprung disease, the rectum is usually small. Okay. Meconium, when you do it on table, the meconium will be passed. You'll see it. It's a long green, you'll never forget it. Okay. But any delayed passage of meconium, you must rule out Hirschsprung disease and cystic fibrosis. Okay, there you go. Again, as well. Here's a meconium, and it has a white head. Okay. So with these, our contrast is not only, it's diagnostic as well as therapeutic. Okay. So when you inject, and they may have to come down again and do another study using high osmolar contrast to treat. If we didn't inject enough contrast, didn't get all the meconium out, we inject more. Further rectal washes using high osmolar contrast is a treatment. Okay. Okay, thank you.